Good afternoon, everyone, and welcome to the ALS Canada webinar series number 4, Mobility and ALS. My name is Melissa Van Tile, and I'm a community lead with ALS Canada, and I'm happy to be spending the next couple hours with you lovely folks, and we're going to be discussing a wide variety of topics with two very knowledgeable presenters. Today, we're very fortunate to have Danielle Carter, who is a senior physiotherapist in the neuromuscular stream from the Ottawa Hospital Rehab Center. Danielle is going to be kicking off our presentation and talking to us today. And then we're going to have Tilly Martin, who is an occupational therapist, also from the Ottawa Hospital Rehabilitation Center. Both of these lovely ladies have prepared an in-depth presentation, and we'll take questions from you at the end. I just want to let you know that if we can't get to your question, or if your question is specific to you, then we would ask that you either reach out directly to the either presenters, who will have their contact information on their presentation, or to reach out to your respected clinic. Okay? So thank you, ladies, for joining us, and I'm going to hand it over to Danielle. Danielle.
So hello, everybody. That was a good way to introduce me, but just I don't know how many of you online right now. It looks like there's about 40 people. I don't know how many of you I already know. Usually I participated in one presentation before, and there were a number of people I knew, and then a number of people from other provinces, from within the province that I haven't met. So it's nice to disseminate the information across the province. So I'm just going to start. Today, the focus of the information I wanted to share with you will be related to mobility, but I also wanted to just give a little bit of an overview of the role of the different physiotherapists you might meet along the way. A lot of the information that we're sharing today, well, it's definitely pertaining to ALS, but I also put to other associated diagnoses, because sometimes people will have a diagnosis similar to ALS or PLS, for example, or PMA. So it's also applicable to other conditions such as MS and things like that. With some specificity, but overall, it's a bit of an overarching topic. So I will move on to the next slide. This is quite a busy slide, and I tried, whoops, I need to go back. Try to keep them a little bit quiet normally, but I wanted to have a good overview of our services. So basically, if you've received a diagnosis that falls under the ALS umbrella, you've been seen by a neurologist, and you'll have been referred to physiatry or physiatrist associated with an ALS clinic. So our role here, and this is where Tilly and I come in. Tilly's currently in another role, but when she was working with the ALS clinic, we received the referral from the physiatrist, and we really act on a consultative basis. So that means that the doctor sends everybody to physio kind of a blanket statement, and we we do an assessment with the patients when we first see them, and we see where they're at, and we offer advice and recommendations based on where they are from a functional perspective. So what are you able to do? How can we optimize that and maintain it as much as possible? So I would say at the ALS clinic, we're really looking at, like Tilly and I, what we can offer is really a bit of an expertise with the diagnosis, because every week we see multiple patients who have ALS, whereas in other environments, even within the hospital itself, the healthcare professionals involved may or see a couple of ALS cases over their whole careers. And it's the same thing for physios in the community, whether they're in a clinic or at home. So the types of goals that we might be looking at, as you can see down here, is provide recommendations and functional training ideas, like what's the best technique to get up from the floor with the types of weaknesses that we see and whatnot. So this is our role here. Now, if something needs to be assessed within the home, it's our job to refer you, and then you would then go, we send a referral for physio, and the physiotherapist will come to your home. And there are different ways that you can access those services. It's either by me sending a referral or your family doctor sending a referral. So any healthcare professional here is HCP. And you can also self-refer. So if you find things are not going well at home and there's some safety issues and whatnot, you can also call the LIN directly, which is the Local Health Integrated Network. It's possible they might have a different name now, but if you look up home care in the province of Ontario, their website will come up and you can call them yourself. So it helps sometimes to have a healthcare professional just to really identify what it is that you want to accomplish. So in those cases, the physio comes in your home. There are limited visits in terms of how many physio sessions you're going to get, and it's covered by OHIP when the goals are identified and you're sort of fit into their treatment criteria. And I kind of see as the physio that goes into the home, they kind of become the environment expert. So we're bringing in the expertise regarding the diagnosis and what to expect. And the physio who has the information about your home, they really become the environment expert. And then we work with you, the patient, who's kind of the expert of you and what you're feeling, and you're the best person to give us that type of information. So the treatment goals for home in this kind of setting would be if you have to learn how to transfer from the toilet to standing in a really small space, that's not something that I could practice with you in clinic or really give you advice about, because we don't, it's hard to reproduce a specific environment here in the hospital, for example. We sometimes ask them to go in because you need to learn how to use a new piece of equipment. So those are in your environment where we're going to reproduce exactly what it is that you're dealing with. Because sometimes we can look at bed mobility here in the clinic on one of our plinths, but our plinths are harder. So when you end up on a soft mattress at home, it certainly can be different. So they really have the equation of what does the environment look like. So that's the second piece. And finally, you can receive physio in the community. This is the type of setting where you can self-refer as well. So you can call and make an appointment at a physio clinic. You can be referred by a healthcare practitioner. So your family doctor might say, I recommend that you go for physio in the community. Or I might say, it looks like you perhaps have tendonitis somewhere, but you're going to need repetitive sessions. So let's find a place close to home where you can be treated for that. It may be covered by OHIP in some cases. So if you're over 65, you might have access to OHIP covered physiotherapy in the community. Or you may access private services as well, where you would have to pay, and you may be reimbursed by insurance if you have some. So the types of treatment goals that we're looking at here would be stuff that's less specific to your neurological diagnosis, but for example, 5 sessions for knee pain or something like that. Or it could be after you've had a fall, we have a specific injury to treat. If we think it could be improved with physio sessions, then we may recommend something in the community if you're able to get yourself to a physio clinic. Okay, so that's kind of the overview. And ideally, when you have different physios involved at the same time, ideally we're going to be able to communicate with each other, and there's going to be a sharing of information so that we're all working together and going in the same direction. So when you are seeing a physio in the community and you come into the ALS clinic, sharing that information can be very helpful. That way we know who to contact and whatnot. So it's very helpful. So going on to mobility changes. So when things start changing from a mobility perspective, is like getting you from point A to point B, what might slow you down? So some of the things that I came up with are typical things that people tell me. It may be shortness of breath. It may be leg fatigue on one side or on both sides, so that after a certain distance your legs start to feel heavy. It could be very specific ankle weakness on one side or both sides, difficulty lifting your toes, for example. It could be just the effort of standing in and of itself. So if you're getting some weakness in your postural muscles, this will cause you to hunch forward. It can cause back pain, and it can create a certain heaviness whenever you're standing or walking. Another common one is maybe balance issues and fear of falling. So then people start to sit a little bit more often, and things can sort of go downhill from there. So it's helpful for you to give some thought sometimes to what it is that's preventing you from doing what you used to do, and that helps us come up with solutions on how to optimize your mobility, how to get you to be able to cover as much ground as possible in a day with the least amount of fatigue possible. So here are some strategies. We just talked, whoops, I want to go back. We just talked about things that might go wrong. So if we look at some strategies to make up for some of those issues that might happen, I would say from a physio perspective, and I think from most patients as well, the goal is to maintain your step count. So you don't have to know exactly how many steps you take in a day, but I think generally we know how much walking we do, and we get familiar with that. And it's important, and sometimes people will have an exercise watch or a Fitbit or something like that, and you can know exactly how many steps you're taking in a day, or how many meters and stuff like that. Or if you keep your phone on you, that's another way you can have an idea. Now, the idea is to use aids and support preventatively in order to help you maintain your step count. So let's talk about aids a little bit. I'm talking about potentially a cane or a walker or something like that. And when I talk about support, I'm talking about potentially something to support your arm if you have severe arm weakness. So support there, because that can change your whole posture. It could be support in the guise of an ankle lace-up brace or something like that, or something more rigid as well. So when we look at the points of weakness and we offer support either through an orthotic or something like that, or a brace, or through support through your arms on a walker, that optimizes the walking pattern, and it usually allows people to cover a lot more steps. And that in turn brings me to the third point here. It helps prevent deconditioning. So some of the changes that are occurring, or the worsening in weakness that you may be feeling once you find out you have an ALS or ALS related diagnosis, some of it happens and is very unavoidable, and it happens because there are changes at the level of the nerve and also at the level of the muscle, and that's something that as far as we know we can't prevent from happening. But if let's say the disease process is mostly affecting one leg and an ankle, or more in particular an ankle, if you start to sit more, and because that ankle can't keep up with the rest of you, at the end of the day you're doing less steps, which means that your knee and your hip on that side is probably getting less of a workout. So those muscle groups can start weakening just by process of deconditioning, without necessarily being the fact that the disease process is attacking those areas. So what we want to do is prevent that deconditioning piece. So we want to make every weak area or weak point, we want to optimize it as best as we can, maintain that step count. And as well, when we use aids and support preventatively or proactively, earlier rather than later, we manage to prevent falls. And when we prevent falls, ideally I like to think that we're preventing injuries. And if we're preventing injuries, we're preventing periods of inactivity. Because if you have to just stop walking or seriously limit the amount of steps you take in a day because you're recovering from a sprained ankle or something, the disease process tends to be opportunistic, and it creates deconditioning in the rest of the limb when you're not exercising or standing and doing all those things. Okay, so those are the things that we can do to keep the walking and the standing as best as it can be for as long as possible, which usually is the ultimate goal for most people. Just going to check the time. Okay, so here are some useful equipment options that we tend to recommend for people throughout the course of the disease process in the context of physiotherapy. So not always, but sometimes people start with a straight cane, and it's surprising how helpful a cane can be from a balance perspective, just because it brings up a lot of information into the hand, and just it makes your base of support a little bit bigger, and it can be very helpful in helping with balance issues and stuff like that. Now, if one has to put a lot of weight on the cane because one of the legs is affected, significantly affected, and you're not able to put as much weight on one side, usually the cane is not enough, and it would really promote off-balance walking patterns. So it would probably really be beneficial to look at a four-wheeled walker. So I have the example there in the top right corner. And this is one of the pieces of equipment that the ALS Society loans for free through their equipment program when the request is done by a healthcare provider, usually a physiotherapist from either of the options that I was showing you earlier on in the presentation. And also, so it could be the ALS clinic physiotherapist, or it could be the home care physiotherapist. And even the OTs can make a request for these pieces of equipment, even if you didn't get to see the physio. So if the OT is comfortable measuring, which I'm sure most home care OTs would be, as well as the ALS clinic OT here, it would be quite appropriate for them to make the recommendation for this if you didn't get to see your physio. Okay, every once in a while, the reason we go with a four-wheeled walker is that you don't have to lift it. So there's an energy conservation piece to that. And usually people, if you have good grip strength in your hands, there are the slow down brakes on these walkers, and you can lock them as well to have a seat and rest. The new generation of walkers, that one that you see there, they're usually about 14 pounds. So, and they close nicely. So if you're not able to get them in a vehicle or something like that, hopefully your spouse is able to do that. But the one that's pictured there is probably one of the least heavy walkers that we have. And because it closes well now, as opposed to the earlier generations of four-wheeled walkers, generally there are no issues getting them in and out of the car. So for small spaces, however, there is the option of the walker at the bottom right of the picture there, and it can have pegs at the front. It can have what we call, it could be skis at the back, actually, with the wheels at the front, so that they can slide along. It's really only good for indoor circumstances and most helpful in small spaces, because that walker is a little bit more narrow than the one up at the top. And it's takes a little bit more energy because it doesn't roll quite as well, and you kind of have to lift the back handles when you're going forward. So not everybody needs a walker like that along the way, but it's an option, and it also is available on loan through the equipment program of the ALS Society. So last but not least, sometimes people are completely fine to walk indoors in their home, even indoors to get to a medical appointment. But for longer distances, like going to the mall, going outside, to enjoy the nice weather or whatnot. It's not very enjoyable if you take your walker and you're exhausted the whole time that you're out. So if you start to be very tired when you're covering long distances, then we start to look to think about wheelchair mobility, and we collaborate with the occupational therapists. So Tilly will talk about that a little bit more, but I want you to know that getting a wheelchair isn't the moment where you can't walk anymore. We want to offer the equipment ahead of time so that you can continue doing the things that you enjoy doing. And even if you can still walk in the home comfortably and whatnot, for longer distances outside, you can have more than one piece of equipment at a time. So I'm sure some of you already know that. Some of you already have more than one piece of equipment on loan through the ALS Society. And when you don't need the piece of equipment anymore, you can let us know and it can get picked up. So going on, I just wanted to talk a little bit about types of fatigue because it does have an impact on mobility. So first of all, I also added the picture up here, which is quite, I want to say, anatomical, but it helps to understand the different types of fatigue. So first of all, there's muscle fatigue, and all of you have felt muscle fatigue before. And it can happen with minimal activity as symptoms advance. And one of the reasons, if you look at this muscle fiber here in the upper right corner, the red tubing, that kind of represents different parts of a muscle fiber. So it's all like a big muscle that has many muscle fibers in it, and all those fibers have different components, and it gets broken down really, really small. It's microscopic. So this is just one muscle fiber, and when we're young and we're in our 20s, all of our muscle fibers are in top shape and they have no problems. So they're all participating, so every muscle fiber doesn't do too much work and everything is great, and we don't need to send a huge message from the nerve here, which is the orange part is the motor neuron, and that's the boss. That's the person who's the part of the system that says please contract so that we can get going. And so as we age, even if there's nothing bad going on or nothing sinister going on, we start to lose access to some of those muscle fibers and the smaller pieces all the way down. So we have less access, they don't perform quite as well. And this is a very lengthy process that lasts from our 20s all the way into our 70s. And as we age, some of these muscle fibers are replaced with fatty tissue. So that explains normal aging process. This is a normal part of aging where it's inevitable, and that explains how we lose a little bit of strength as we age, even when we're aging very, very well. Okay, so muscle fatigue essentially is as I'm asking my muscle to perform over and over and over again, some of these fibers are going to wipe out and they're going to say, you know what, I have to stop now. It's too much. It's a little bit like a team of rowers where somebody will say, I have to take a little break. So they're still going through the motions of the rowing, but they might not be working the hardest on the boat. And the same thing happens with those muscle fibers. Some of them tap out, and then as we push ourselves, we have less access to those muscle fibers. And sometimes with the nerve, we can talk louder, we can be more willful, we can say, I really want to lift that leg, I'm really going to send the message. And that is when we really start pushing ourselves. And that push can lead from muscle fatigue to nerve fatigue. Okay, and how do I know the difference between the two? First of all, muscle fatigue, you can continue walking and it's not that uncomfortable. Nerve fatigue, however, if you're really pushing, you're not going to have a lot of gas in the tank. You're eventually, you're really going to run out. Okay, so if we look at the muscle fatigue here as explained on the left, you know for sure you're only having muscle fatigue if you sit down for 20 to 30 minutes and you have complete recovery when you stand up and walk. And you know that because when you stand, it's like you didn't exercise at all, everything is fine. Okay, this type of fatigue is not really worrisome. If you take a short rest when you feel like this, you'll recover well and you can probably perform fairly well throughout the day. And Tilly's going to talk about this a little bit more. I saw she has a diagram that I thought was really helpful, so she'll talk about this a bit more. Nerve fatigue will come on when muscle fatigue is ignored. And when you get up from 30 minutes of sitting, your legs are going to feel no better than when you sat. So you've pushed and you've pushed and you've pushed yourself. You get to that point of nerve fatigue and you rest and you get up and you're done for the day. So we don't actually know, but it may be bad for disease progression. So it's not advisable to push into nerve fatigue. Some of you may not have felt nerve fatigue before, and that's good. And if you've felt it before, it's not the end of the world. Just what you need to do, it's a sign for you to rethink how you spend your energy so that you rest as soon as you feel muscle fatigue before you push into nerve fatigue. So it's a little bit of a continuum, okay? But you have to pay attention to your symptoms so that you can, and this, what ends up happening is that people wake up with a depleted energy bank from one day to the next. So sometimes it happens just sporadically. You've gone with your grandkids maybe somewhere, or your children, you've gone somewhere and you really pushed yourself because you really wanted to enjoy your day, and then you're in bed for a day or two, and that's okay. It's like a budgeted moment, and that's fine. But if you're getting to nerve fatigue on a regular basis, you really need to rethink how you're spending your energy. Okay, a couple of quick tips on how to avoid fatigue. Energy conservation is your kind of your best bet, and again, Tilly's going to talk about that. One thing you can do is look at support, and I talked about ankle braces a little bit. If you have a weak ankle or balance problems, that can be helpful. It can do some of the work for you. Frequent breaks is another one, so short breaks so that you can get back at it without running into that wall. The use of walking aids, so walkers, for example, or the use of wheelchair for long distances. And really the idea is you save energy, you step more, and then you get to maintain your endurance. Okay. One last slide for the take-home message. Remember to listen to your body, use aids and support to maintain your step count, rest frequently, which is a good aspect of pacing. And pacing is a huge topic in and of itself. So we talk about it often in clinic, and I'm sure in occupational therapy as well. So it's about identifying things that take a lot of energy and figuring out how can we make that eat up less of your energy. So I can stop here. I think we'll have to do the questions at the end because I'm almost at 30 minutes. And I did prepare 2 slides on exercise if we have a moment, just because exercise can impact mobility. So maybe we'll have time to get to it after. So you can go ahead and jump in, Melissa.
Thank you very much. That was wonderful. So we do have a couple questions, just 3. So I'll just take a few minutes to ask you those questions, okay?
Okay, yeah.
So from Corey. Corey asks, I have ALS in both arms. I am limited on any kind of movement. I am not walking as much because of it. I find myself unbalanced and I don't know what to do with that. I don't know of any support. I have no muscle structure in the back, so I'm starting to hunch over. More or any advice would be greatly appreciated.
Well, that's a really good question because there are people who have more limitations or weakness in their arms than they do in their legs, and it can really throw off someone's balance. So surprisingly, especially if there's what we call an ergonomic handle on a walker, if you are able to just gently place your hand on a walker with those types of handles, a walker can be helpful because it just supports your arms a little bit, so it stops pulling you forward when you don't have that muscle tone in your shoulder girdle. So a walker like that could be an option. We also have walkers that have what we call a gutter attachment. It looks a little bit like a trough. So sometimes people are able to have someone help them get the arms in the gutter attachment, and they're able to direct a little bit with some trunk movement, the walker. That way, it takes away some of that pull, some of that downward pull again, and it helps with stability. It doesn't work with everybody, but when people come into the clinic, this is one of those specialty things that some home care therapists may not have seen, or a lot of people would just assume it's not going to work. But in the clinic, we do have access to a walker like that we can try and see if it's helpful for people to then see. And through the ALS Society, you can order the parts or the gutter attachment that are required. So I have done that for patients in the past, where we look at a walker. Sometimes they only need that attachment on one side and they can maneuver the walker with the other. Another thing that may be available is a Give More sling. So Corey, I didn't put my information on my slide. I meant to before I got on. I thought about it before we started, but while Tilly is doing her presentation, I'll write something up in the chat if I can, and you can send me an email. I could send you some links, and if anybody else is interested as well, about arm sling that's called a Give More sling, and it helps just give a little bit of upward support. Again, we have one in clinic that we can try with people, but it's hard to find in the community. So that's the kind of thing that I like to try in the clinic here. It doesn't work for everybody, and generally people need assistance to put it on. So especially if both sides are affected, so you would require some assistance with that. But there would be things to try, Corey. So I don't know if you're attending the ALS clinic other than here, or if I don't recognize the name without the last name and a face and all that. But you can bring it up with me at your next visit if you're part of the ALS clinic here, or I can send you the links and you could share that with your ALS clinic wherever you're going, if that's the case.
Perfect, thank you.
Okay.
And that would be great if you could share your information in the chat. That's lovely. Okay, so we have another question from Sheila, and I think I might be able to answer part of it. It says, what is the wait time to receive the devices? So Sheila, if you are referring to the ALS loan pool, then from the time that we receive the referral from either the OT or the PT, we like to normally say 7 to 14 days. Sometimes, given the popularity of certain equipment, it can be a little bit longer. But once we receive your request, we will let you know that it is usually 7 to 14 days. We do work with a variety of vendors, so we do try to get the equipment out to individuals as soon as possible. And we try to relay that information through your OT. So I'm thinking that is what your question is referring to. If it's not, please feel free to pop back into the chat and just clarify. Okay. And we have one more question from Graham. And Graham's question is, I have difficulty in determining the difference between muscle fatigue and nerve fatigue. How can I better discriminate while getting in my steps?
I'm trying to figure out how to put the screen back on between the two different types of fatigue. Go to webinar. There we go. No? Oh, yeah. Let me share my screen again, if I can. Might not be able to figure it out. No one? Click to start share screen. And then there we are. Can you see now the screen?
Yes, we can see your screen.
Yeah. Oops. Okay, so muscle fatigue is the kind of fatigue that you, like in the past, if you've ever exercised, you've gone on a treadmill or you've gone for a walk outside. Once you stop, if you've pushed yourself a little bit to a point of exercise and training, your legs might feel a little bit shaky. And you're like, I feel that, I think I'm gonna have a seat. So it's kind of like a preliminary fatigue, as in I've pushed myself. And it can be a little bit of like leg heaviness or that kind of thing. Nerve fatigue comes on after you push yourself. So let's say you ignore that shakiness, it'll turn into a heaviness. So that's sort of the quality of the fatigue is a little bit different, but not everybody manages to really figure that out with just the quality of it. What's really the telltale sign is, let's say you've been working hard and you sat down for a meal with your family and you sit for 30 minutes, or you sit after your exercise to recover. If you hit the 30-minute mark of sitting down and you get back up and you still feel that heaviness in your legs or really, really shaky, so your performance after a rest is the same as before you had your rest or very close to it, chances are you're falling into the nerve fatigue part, which is best avoided, really, because what happens when we hit nerve fatigue is people crash, and then it costs them for the rest of the day and into the next day, and then you're never really getting to your peak performance. So it's costing you on a regular basis, and you're not ever really able to get on top of it. It's a little bit like overspending on your budget, and you're waiting for that next pay to come in, and you've overspent before it even comes in, you know. So it's a little bit more intense, and it will not recover. So if you've ever had to spend a whole day resting, or a whole day where you're not able to do your normal activities, chances are the day before you hit nerve fatigue. Therefore, you need to consider, what is it that I did that brought me to that point, so you can try to readjust and make it less of a symptom. Okay.
Perfect. Thank you very much, Danielle. Okay. All right, we're going to hand it over to Tilly now.
Great. Good. So everybody can see my presentation?
Yes, correct.
Perfect. Okay, great. So my name is Tilly, and I'm an occupational therapist. And as Danielle mentioned, I usually work at the ALS clinic in Ottawa with her, but I've recently taken a contract in another position. So I'm not currently there, but I have served it over the past year. So I'll give a little bit of, so this is the agenda of what I'm going to be covering today. So just a bit more information on what occupational therapy is and where we work. A little bit more information on energy conservation following all of the review that Danielle gave on what's actually happening in our bodies in terms of muscle fatigue and nerve fatigue and what we can do about it. Then we'll look at equipment needs, the equipment program, and funding that might be useful. So the role of occupational therapy. So occupation is just a fancy word for the activities that we do in our everyday life. So it can range from self-care activities like bathing, dressing, toileting, which we call activities of daily living. And it can range to things we do around the home, cleaning, cooking, outdoor maintenance, to leisure, to productivity. And as we know, there's a lot of things that can come and impact the way we engage in these occupations. For example, a change in mobility and an increase in fatigue, a loss of balance, change in strength, which we might all see in the ALS clientele. So it can be difficult to get through those day-to-day things, and that's what we're looking at. How are these occupations impacted, and what can we put in place to make them safer, more comfortable, more accessible, and easier to engage in? So with ALS and the associated conditions, a lot of what we will be looking at in terms of recommendations are more of like a compensation approach. So strategies to compensate this change. So as I said, like I work at the clinic where we work with other healthcare professionals, with Danielle, physiotherapist, a social worker, dietitian, speech language pathologist, nurses, doctors. And we typically see patients that are as outpatients, so that are not admitted in the rehab center or in the hospital. So these visits are done in person or virtually. So All this being said, we see them in the context of the clinic. So we don't do home visits. So in order to make sure that our recommendations make sense in the context of your home, we often work closely with other therapists that work in the community. So just like Danielle mentioned, they might work through home care services, which was formerly the LIN or CCAC, or even privately. So by working with them and, seeing how things are actually going at home in your environment, it can offer a lot of insight into if our recommendations make sense, if they fit, and other specific needs. And with working with us at the ALS clinic and being aware of resources and the changes that we might anticipate, usually it offers like comprehensive follow-up. So jumping into the energy conservation that Danielle covered really well, the course of ALS can be unpredictable, but fatigue is an outcome that we might expect, whether it's muscle fatigue or nerve fatigue. And it can also range, from mildly tired to extreme exhaustion, like Danielle reviewed. And we know that fatigue can really impact the way that we engage in our occupations. So some of the strategies we look at will try and minimize the symptoms through effective management. And we can do this by recognizing the signs of fatigue, knowing which factors might worsen those symptoms, and learning how to conserve energy. So I'm sure you might be aware of the signs of fatigue, but they might include slower body movement, slower speech responses, shortness of breath, might include some change in our behavior or emotional state with some irritability or anxiety. Can include like a loss of balance, loss of mobility, a lack of enjoyment of previous enjoyed experiences. And the factors that might make this fatigue worse can be immobility or overexertion, sleep disruption, pain, malnutrition, stress, a lack of assistance available, a lack of resources, and an inaccessible environment. All of those things can make our fatigue worse or contribute to it. So looking at strategies, as Danielle mentioned, pacing is a subject that we go back to over and over again and takes such a big space in terms of how we're managing those symptoms. So what does pacing need? Pacing is taking a break before you need one, which is a kind of a hard concept. It's easier, it makes sense when we're saying it out loud, but in practice, it can be pretty difficult. So we really encourage people to stop and rest often. And when we do that, we might find that we're able to complete more than if we try to do it all at once. So we can alternate activities with periods of rest, schedule regular rest periods each day when we start to get to know our schedule. So here I have a little diagram that we see that we know when we take our time between doing something and resting and resting, we might be able to do a lot more than if we just go, and then we end up sick and taking a longer time to recover. Another strategy would be prioritizing. So allowing enough energy to enjoy at least one valued experience each day, or as Danielle had mentioned too, sometimes we might budget our energy so that we can do something that might take everything for the week, but it's something that was very, very important to us. Knowing, what's the difference between something that I should be doing, something that I can be doing, and something I want to be doing as well, to be able to plan our day. And speaking of planning, that's another strategy to use to manage our energy. So planning our activities and gathering things before we start, knowing how our day is going to look like, when do we typically have more energy in that day, or knowing what is going to take energy and how to schedule breaks. Planning ahead in terms of how we're going to be doing the activity. So sitting instead of standing, using possible shortcuts, obtaining assistance in completing tasks if we need help. And lastly, some equipment. So using assistive devices and equipment to help with that energy and compensate for the loss of strength. So learning methods of making everyday tasks easier, and that equipment is there for that reason. So as Danielle mentioned, if you're having trouble walking, perhaps using a walker, or perhaps considering using a wheelchair if it can save you a ton of energy. Make your living environment more accessible for daily activities and promoting energy conservation. So perhaps moving a bed to another location or relocating personal items. Those might be examples on how our environment can be, can promote that energy conservation and minimize the movements we need to do or the back and forth and so forth. So it's a good segue into the equipment portion. So as we just saw when talking about energy conservation, equipment takes on a big part of managing the symptoms, and having the right equipment at the right time can improve your quality of life and extend your independence. So sometimes having it in place before it is needed can also avoid a crisis. In occupational therapy, we look at equipment as a way to help participate and engage in an important occupation in a safe, energy efficient, and comfortable way. So from that lens, we'll look at equipment pertaining to different spheres. So I'll go through each of these. So ADL, so activities of daily living, which I mentioned earlier, can include getting dressed, going to the bathroom, feeding, grooming, all of those things. So sometimes looking at dressing aids for assistance or toileting aids, sometimes adaptive utensils, those things can really help with that loss of mobility or the fatigue. The positioning while doing those activities is also important. How close are you to the sink? Are you sitting? Do you have proper arm support? Are you taking breaks? Is everything set up to avoid bending forward, reaching over and over again? So really looking at the environment, the equipment, how we're doing the task. When we're looking at bathroom equipment, we might be recommending shower seats, tub lifts, toilet seats, grab bars. Sometimes at the clinic, we're able to make recommendations based on our observations, but other times we might really rely on the community occupational therapy for an assessment because sometimes the bathroom might be quite inaccessible and we have to be creative into what we can recommend and how we can make this work. For the bedroom, sleep is a really important occupation and can provide a lot of rest. And the types of equipment we might look at to make this easier might be hospital beds for positioning, might make breathing a lot easier, make it more comfortable. We can look at different types of mattresses, whether it's just a standard foam mattress, do we need an air alternating pressure relief mattress for decreased mobility, looking at bed rails, transfer poles to make those getting in and out of the bed easier. We can look at IEDLs, which are instrumental activities of daily living, which might include cooking. So sometimes there's different assistive devices used for cutting things, peeling, preparing meals. Can we look at stools to sit on? Can we look at services that might be available? Can we plan ahead? Same things with the homemaking. When we're looking at functional mobility, usually looking at wheelchair needs, whether it be for just appointments or for around the house. And there's various types of wheelchairs that exist. And at the clinic, we can take measurements and talk about the most appropriate option. So there's two categories. There's a manual wheelchair or a power wheelchair. And within the manual wheelchair category, there's different types of manual wheelchairs. That might be transport wheelchairs, which are foldable chairs. They don't offer much support, but they can't get you from point A to point B to save you a ton of energy. Or there might be more specialized manual wheelchairs that you can either use your feet to get around the house or your arms. You just have to be quite conscious of how much energy self-propelling might take, how it fits within your environment, how you'll be using it. And there's also tilt wheelchairs, which you're not able to self-propel in them, but they do offer a change in position and how you are sitting in it. So tilting back to offer a break for your posture and postural muscles. So with a healthcare professional assessment, typically an occupational therapy assessment, we can really see what those needs are and what type of wheelchair might be best suited for you. And those types of wheelchairs are available through the ALS Society Equipment Loan Program, which I'll look over a little bit more in detail in the following slides. So those are the types of manual wheelchairs, and then there's the power wheelchairs, which might include like a scooter or a wheelchair with a joystick that you don't have to propel with your arms or your legs actively, but that it uses a motor to get around. When it comes to motorized wheelchairs, we typically refer to the community occupational therapist, as there are some safety risks to be aware of, and it will be specific on how you'll use it in your environment. It also requires pretty close monitoring and follow-up. So that's all the functional mobility. Looking at the home and community access, we might look at stair lifts, ramps, parking passes, anything that can make it easier to get in and out of your house and around the community. And of course, there's always, other things that might pop up, like assistive devices for equipment for childcare, kayaking, video games, anything that might, come up that would be more specific to a client. So that's a really long list of equipment, and as you can imagine, a lot of equipment can be expensive. So thankfully, we do have access to the ALS Society Equipment Program, which I know Danielle had mentioned. So there's that loan equipment program where they have numerous vendors as partners, and they have a pool of used equipment that we can request. So standard wheelchairs, power wheelchairs, bathroom equipment, hospital beds, mattresses. They deliver it directly to the client's home. If we're looking at the funding assistance program, they can also sometimes have resources to help offset the cost of certain leased or rented equipment, like stair lifts, if it fits within the, because it goes by household income. So it's a really, really good resource to use for equipment needs. Especially for wheelchairs, if we need something more specific in terms of wheelchairs, something that might be more customized, that the ALS Society does not carry, we might have to go through other programs or other vendors to get something more specific, to get it prescribed, in which case usually a private occupational therapist or a home care occupational therapist will go through to ensure that follow-up and to make sure that you obtain what you need. And that's where we look at other funding sources like the Assistive Devices Program. So you might have heard of it. It's ADP. Stands for Assistive Devices Program, and it's a government program that helps people with long-term physical disabilities pay for customized equipment, like wheelchairs. So the community occupational therapist will typically go through that assessment with you. And once approved for the funding, because typically there's a pretty low rate of if it's not approved. But if it is approved, the program covers 75% of the costs for most equipment and supplies. And then they bill the supplier for that 75%, and then you pay the next 25%. So as I said, to obtain the funding, the healthcare professional would first assess you and your needs, and then you would try the equipment with a vendor, and the custom wheelchair can be ordered. The vendor gives you a quote, and then the funding is sent to the government of Ontario. The other source of funding might be March of Dimes for equipment or home adaptation. You have to apply for it, and it is income based. But for March of Dimes, which isn't the case for ADP, the applicant can't purchase the equipment before receiving approval, and the approval might take a few weeks to a few months, which is sometimes too long to wait when we really need something. So it's not an option we often use, but it's still an option that we let the applicant know about. I realize I flew through that information just because I thought that it would take a very long time to go through the different types of equipment. So I'm open to questions and perhaps delve a bit more specifically into different equipment needs or energy conservation strategies.
Okay, thank you so much, Tilly. So we do have a question from Callie, and her question is, what are the recommendations for preventing pressure sores? How often should a person with ALS position be adjusted during the day, and or cushions, etc.?
That's a great question. So yeah, when there's a decline in mobility, then it's quite hard to change positions and just to offset the pressure. And one of the consequences of that is pressure injury. So the first thing we'll do is to try and prevent those, but if it's already happening, we will look at where the person is spending most of their day and how they're positioned within that, the types of surfaces that they're sitting on. So we want to make sure that we're looking at pressure relieving surfaces if the person cannot change their position on their own. So that might be an air cushion or an air mattress. There's air mattresses that provide pressure relief and alternating air that can move and kind of shift where most of the weight will be in, like for the person in the bed. If it's on a wheelchair, we can also use a cushion, but we might also be looking at a wheelchair that tilts so that a caregiver or an attendant or whoever can also change the person's position in that chair. We typically say to reposition every 2 hours at the minimum. In a wheelchair, when someone can't reposition themselves, we do recommend that they are supervised so that the care attendant can move the wheelchair for the person, reposition, tilt them back, bring them back to bed, etc. In the bed, it can be quite difficult to reposition someone every 2 hours, especially overnight, and that's where we'll try and recommend using a pressure relieving mattress with an air alternating mattress that can shift that weight. We're also looking at what clothes the person is wearing. So if they're wearing clothes that have a lot of seams, that have pockets, if there's a lot of layers, if there's briefs, and if there's moisture, those are all things that can contribute to pressure injuries as well that we want to be quite mindful of. So checking for the skin, making sure the person's eating well, all that type of stuff. I hope that answers your question.
Thank you very much. Okay, we have another question from Victor. Victor asks, can you discuss caloric intake versus energy use when chewing and swallowing is difficult?
That's a good question. I think it would be more appropriate for the speech language pathologist or dietitian they might have more information on that. When it comes to like how you're feeding yourself, then we'll look at how much energy that takes. What, if it's a lot of energy, and like, are you reaching for the food? Do you have arm support? Is what you're putting, is a utensil too heavy? Are you spending most of your energy trying to get the food on the fork or the utensil? So we can look at that, but in terms of specific caloric intake and chewing, I think the speech language pathologist and the dietitian might be better at answering that.
Thank you. Okay, and we have a question from Graham. It's regarding conserving your energy. Should a manual wheelchair conserve better than a rollator? I'm lower limb onset, and if so, does a lighter wheelchair by extension improve conservation?
It can to a certain extent. I think Danielle might have information on that too. I think it depends how you're using them. And how much energy it's taking to self-propel in the chair. Are you the one pushing the chair, or like, you know, using your arms or your legs, or is someone else pushing them for you for those long distances? Typically, we might recommend that someone have both. They can both have the rollator. That might be easier to maneuver in a tight space or indoors or what have you. And then we can recommend a wheelchair to use on uneven surfaces for long distances, or even for appointments when there's really long days ahead and you want to make sure that you're sitting for most of them, or, you know, minimizing those needs to kind of get up and sit down over and over again. So they can be used together. When we prescribe a wheelchair, when we recommend a wheelchair, it doesn't mean that we're saying never walk again. So I think it's based on the context and the environment in which it's used. Danielle, is there anything that we should add about that in terms of mobility and rollator versus wheelchair?
I think it's really a case-by-case basis. I'm really agreeing, like I totally agree with you that having both pieces of equipment could be very useful. So I think, you know, walking to the point that you're able, and when you start to feel fatigue or whatnot, then you could transfer to the chair and mobilize with more use of your arms and give your legs a break, so you could even alternate throughout the day. I think that would probably be the best case scenario. And if there's one, like using one aid versus the other starts feeling, you know, too much, then you spend a bit of time in using the other piece of equipment. But I think alternating would probably be ideal, because you're throughout the day decreasing the load on your legs versus your arms as you alternate these two pieces of equipment. So yeah.
Okay, thank you. So Danielle, the next question is for you. So it says, for Danielle, you mentioned exercise programs. Could you elaborate more on these programs? Larry is asking this question.
Sure. So I don't know if it makes a difference if my screen is on or not. Am I able to share my screen again, or I think you'll have to adjust something?
I'll just, okay, I think I stopped sharing.
Share my screen.
There you go.
Yeah. To my,
you're good.
You can see my presentation?
Not yet.
Right, there you go. Yeah, it's back. Good job.
Oops, it's just taking a moment. Okay, I'm going to go back to those two slides at the end. To exercise or not to exercise, that is the question. So really exercising is really a question of how do you feel and whatnot. So there are some people, you may even hear this from doctors, that will say, you know, you now have this diagnosis, you shouldn't exercise at all. In fact, 20 years ago, we would tell people who had MS that they should not exercise, and it was all about energy conservation. So energy conservation is very appropriate, but there are some studies underway right now about the effects of exercise on function with respects to ALS. I think it's in Australia, but the verdict's not quite out, which really doesn't mean that we don't exactly know. It just means that the study's not complete. But we already have a pretty good idea that exercise can be beneficial. The important piece is the intensity of the exercise, and are you getting to nerve fatigue? So I made a little bit of a checklist here that I think is appropriate to look at. if you have a diagnosis of any type of neurological condition, if you've never exercised in your life and you absolutely hate it, this is not the time to be implementing an exercise program. I tell people you should exercise if it brings you pleasure, if it makes you feel productive, if you feel okay after you exercise. So check yes if exercise is already part of my life. Is exercise fun for me? If it is, then you're gonna reap other benefits from it, even just from a mental health perspective. So absolutely go for it. In terms of exercise, you must respect your abilities, and it comes back down to muscle fatigue versus nerve fatigue again. So if I respect muscle fatigue to avoid nerve fatigue, and I'm able to do that well, then it's okay to exercise for sure. And do I have energy for other things during the day as well? Then absolutely it could be indicated. We usually recommend sub-max training principles, which means very, very low loading. So if anybody's thinking of using weights, gravity even in and of itself could be very effective. You don't necessarily have to be lifting dumbbells or anything like that. TheraBands can work as well. So sub-max. And so in traditional training, we usually say that for strengthening, you want to be doing 3 sets of 10 to 12 reps. Well, definitely not in this case. And I tell people try and do 1 set of 6 to 10. If you get really good, maybe 1 set of 12. But beyond that, no more than that, and then take a day's rest in between your exercise programs. It's always helpful to have the physio or somebody maybe make some specific exercise recommendations if you feel that you can do it. But it really requires some fine tuning on your part. How do I feel? Should I do more? Should I do a bit less? Once you do get your exercises. And absolutely not exercise if you don't like it, if you feel bad when you exercise, if it takes hours or days to recover, no matter how little I do, or if when you do exercise, you don't have the energy to do other things, it's not a good time to introduce exercise. There is a point at which we sacrifice exercise for function, and we want people to put all of their energy into functional activities and resting and pacing and all of that. So it's not a firm no on the exercise, but you really have to make sure you're checking all the boxes on the left there. And there are a couple, like practicing sit to stand. Consecutive sit to stand is a very functional activity that I like to recommend to people to maintain that ability to stand and sit and stay strong. Not 20 in a row, like 5 to 10 if people are able to do it, or 5 in the morning in a row and then 5 in the evening. But you really have to gauge how you're feeling when you're doing these types of exercise. And of course, it depends on, you could be asking me for shoulder exercises and whatnot. Generally, movement is good, but keep the intensity low by not loading and not doing ever more than 10, and never repeating the same exercise 2 days in a row, unless it's just a mobility exercise, like something like that. It's mobility and it's not super heavy. Okay. I hope that answers a question, but honestly, we could do a whole half hour on exercise.
That's great. Thank you. So just on the theme of exercise, we have another question from Angela, and Angela is asking any advice on getting steps in the wintertime.
Getting steps in the wintertime. That's a really good one. I have had some people who, have their Fitbit or whatnot. So they're very, they're keeping an eye on their steps. So I've had some people that were well enough to have supervision from a spouse to walk down the stairs into the basement and to use that wider open space in the basement to walk around. Some options could be mall walking. Again, it really depends if there are days where it's not going to be safe for you to go outside to actually get to the mall. So I would skip those days for sure. A lot of people that I have seen in the context of the ALS clinic and other diagnoses, neurological diagnoses, I don't know if people have heard about a Kubi machine. But it's kind of like a little stepper that you can put under your desk, or you could put it in front of you at the kitchen table or whatnot. And it's just this little motion here. I think you guys can see my camera. And people can and in fact, any exercise, if you start and you're only able to do 2 minutes at a time at first, bring the intensity all the way down, do your 2 minutes, and then gradually over time, add 30 seconds, add a minute, see if you can make it to 5 minutes and that kind of thing. So people do, I do have people who have degenerative conditions who manage to go from like 3 minutes of consecutive stepping to up to 15 minutes of consecutive stepping. Ideally, if you want to get better at walking, you should walk. But if that's not possible, in lieu of not doing anything, doing an exercise like the kubi or something, even just standing on the spot in place while you're watching a TV show or something with a walker in front of you, very doable and very helpful as well for balance reactions and getting your steps in. So we do have to get a bit creative sometimes, for sure.
Perfect, thank you. And Larry just wanted to say thank you for answering his question, as your answer shed a lot of light on him. So, thank you.
Okay.
So that looks like the end of the questions that I can see. So we're at about 2:11, and if we don't have any more questions, then we can wrap up. I would like to thank Danielle and Tilly for amazing presentations, so thorough. Thank you so very much. It's been a very informative webinar. I just want to reiterate that Tilly did share her information and Danielle did put her contact in the chat. So for anybody watching that would like to directly contact them, please feel free to get that information. Also, our webinar is recorded, so it will be recorded and made available on our social media and for anybody who would like a copy of it. So some people were asking about Danielle's presentation. So once that is finalized, we can pass that out. So I'd like to thank Danielle and Tilly on behalf of ALS Canada for making our webinar series number 4 so great and so successful. Thank you both very much.
You're welcome.
Thank you.
Well, with that, I will thank everybody. And oh, we just have one more question coming in, and this is from Victor. And Victor's asking, are there different types of ALS, bulbar versus others, or has this been discussed? I'm not sure if either of you want to take it, or I can take a stab at answering it. It's whatever you feel comfortable with.
Tilly, did you want to go, or?
No, you can go.
Yeah. So bulbar is definitely one of the forms that we see, and bulbar is really talks more about swallowing issues, stuff having to do with this area of the body, swallowing, speech, facial weakness and stuff like that. So that's definitely considered bulbar. I believe the other type is called spinal, or but will affect more. It can be like limb onset. So sometimes we see more of the upper extremities, and sometimes we see more of the lower extremities. I honestly am trying to remember if there's a specific name. Maybe you know, Melissa?
We usually just refer to limb onset, either bulbar or limb onset. So that's what usually we do.
Yeah. So, but we do in the limb onset category. Sometimes people have more of their lower extremities affected. Sometimes it's more the arms. So yeah, and then occasionally we'll have somebody who's not even really limb onset or bulbar onset, but more trunk weakness. So affecting more some breathing muscles and then core strength, postural stuff. So it can be certainly different things. But I thought there were only 2 different kinds.
Thank you. That is how I would have answered also. Thank you.
Okay.
All right, so that is no more questions. So again, I just want to thank everyone for taking time out of their day to join our webinar. We encourage you to join us in October for our webinar number 5, and we will be sending out a flyer probably about mid-September to do some advertising on that. But again, thank you so much to Danielle and Tilly for taking time today. People are saying thank you, best wishes, and yes, thank you, and everyone have a lovely day.
Okay. Take care, everybody.
Thank you, ladies.